Okay, we'll go ahead and get started. Thank you for joining, everyone. And just reminding everyone that joined, it's a webinar, so you are in listen mode only. Everyone's muted, but you can definitely send questions and messages through the chat box, and I'll kind of monitor that. And if there's questions, I'll let the panelists know. This is our food for thought, and we have Dr. Corinne South, the founder of ElderHealth, and then Peggy Schmidt, Laura Almer, and then Melissa Kuhn. And then we kind of have the intros on the board there so everybody can read a little bit more about you. Or if you want to go ahead and do another intro. And my name's Audra Barney with Harmony.
Thank you.
Wonderful. Hi, guys. Thank you all so much for coming. Thanks for having us, Audra and Harmony Hospice. I'll just give a quick intro about ElderHealth. ElderHealth is a medical practice that we started earlier this year, which is a home-based primary care model with a main focus to try to help people and their families get the support they need that are trying to stay home to manage neurocognitive disorders. So that's kind of the basis of our group. I'm Dr. Self, Melissa Kuhn, nurse, Peggy Schmidt, nurse practitioner, and Laura Almers, our licensed clinical social worker.
Hello, everyone.
So a big kind of part of our practice is we like to try to empower people to see behaviors as a communication, not just as the person or the powers that be trying to make their life harder, but actually trying to think about what the person might be trying to say through their behaviors that they aren't able to verbalize with words like we might be able to. So I will just first say that we always want to think about the simple things when someone's showing agitated behaviors that we all always think about, like pain or hunger, or the temperature is too hot or too cold, or they don't like the music that's playing. And then Laura is going to give kind of her overview of how she views, how she kind of has a framework for thinking about behaviors as communication.
Thank you, Dr. Self, and welcome to everyone. For our discussion today, we both utilized our backgrounds, experiences, personal and professional, to inform the information. And then we also consulted with 3 books, and we can get Audra the names more specifically later if she wanted to send them out. But one is The Dementia Concept by author Joshua Freitas. The other is a book entitled I'm Still Here, John Seisel. And finally, one by an MSW social worker, Mary Mahler, Alzheimer's Through the Stages. 3 books that we all would highly recommend as, you know, a place to go to as a resource. So in the context of behavior as a form of communication, there are 3 foundations that we thought can help guide our discussion today, and also helpful going forward for anyone in managing behaviors. So one is the understanding that due to the result of changes in the brain, the way a person is able to relate to others and respond to the environment around them will also change. So kind of keeping that in mind as a foundational point of reference. The other point we like to make is that you as caregivers or care partners, however you might identify yourself today in our audience, you are going through changes as well along with this. So as someone you're in relationship with or that you're serving or caring for is experiencing changes, you too are needing to adapt. So I mentioned that to say it's a sort of a holistic, everyone part of the equation situation, and to be soft and kind with yourself as you approach these things. Secondly, in this context, we invite you to consider what you know or to learn about the traits or the background interests from a person's past as well as who they are now, or what the needs are now, given these changes that are happening cognitively and due to disease impact and disease progression. So the past, knowing and being curious and asking about that, and then also, sort of joining that up with, but what's happening now as well, because some things certainly change. And finally, we invite you to try and approach, when we're talking about managing behaviors or thinking about them as communication, that aims less at sort of a solution focused, like I'm going to fix it, problem solving mode, pulling away if you can from that urge to orient to reality, or try to understand something as rational or irrational before you move to engage with someone. And our invitation today is to make it more about joining with that person who is in front of you, meeting them right where they are, validating feelings in those moments of real distress or escalation of a behavior, offering simple responses, and then waiting, using silence in between, and becoming more comfortable with that as the person who is experiencing cognitive changes needs to process sometimes. That information has to get in. So taking a little time, keeping responses simple, and then finally, as the rest of my wonderful team and panel will begin to talk about, thinking from a very multi-sensory, holistic way when you consider, how do we intervene? How do we make something that is very distressing or very overwhelming seem a little bit better? So those three kind of foundational or building blocks can be helpful. I'll turn it back over to Dr. Self and Melissa and Becky.
Thanks, Laura. So we thought what we would do kind of to make this more tangible is just go through some problem or behaviors or difficult circumstances that people face on a daily basis, and kind of troubleshoot how we might approach the situation to improve the behavior. And if anyone has questions, and we'll also try to use examples, and if anyone has any questions, just pop them into the chat, and Audra can kind of interrupt us, and we can answer the questions as we go. So we're going to start by talking about when people have resistance to self-care, because we know that's a huge challenge and a huge burden, especially when someone comes and says, well, this is impossible because they won't shower and I haven't showered them in a week and they get UTIs, and how am I going to move forward from here? So
things for that particular issue that I found very helpful. We have what's called a bath poncho at ElderHealth, and it's a towel that basically goes over them like a poncho, and the goal being to preserve dignity in that person. So they're not, again, their minds are in and out. So when you come in and you're just taking off their clothes, that can feel very disruptive to them, but you put the towel on, and then the caregiver bathes under the towel. So it helps with them not being cold, but it also provides them a sense of dignity and keeps their clothing on, so to speak. The other thing is not showing pictures, visualizations before you start care. So meaning if you're going to brush somebody's teeth, you show them the picture. Less words, more pictures. It's hard to understand what you're saying, but if you show the picture and you wait a minute, we're going to brush your teeth, and then you show the picture where we're going to do the bath, so they know what's coming. Use the pictures versus trying to explain. Again, words overwhelming, pictures are easier for people to understand, especially with dementia. Try to find out what made baths pleasant before, or showers pleasant before. If it was somebody who hated showers and never took a shower, then maybe the shower is not the way to go. Did they take morning baths or evening baths? Simple things like this can make that care a lot easier. Do they like really hot water? I know for me, if you put me in that lukewarm bath, I'm miserable. It's awful. So if they're a hot bath person, you find out. Did they use a certain kind of bath product or whatever that you can bring back from the past to make them remember that this is an enjoyable experience and feel good, use that. So kind of, and using music, put on the Spotify or your favorite music on YouTube or their favorite music on YouTube. So, because that makes all of us enjoy that part better. And it's a distraction. So those are some easy things that can sometimes make a big difference. Sometimes you do need to intervene with medicine, and that's another talk for another day. But for the most part, just some simple things that can really make those caregivers have a lot easier time getting a bath. I can't stress enough that routine is really important. So if you, and that takes about 2 weeks to establish. So if you decide we're going to give this shower every day at 7 o'clock, then you stick to it, even when it's weekends or whatever, because that groundwork can lay tracks and that can be remembered, for lack of a better term, in someone with dementia. Whereas if you're just trying to do it whenever they don't have any idea of what's coming. So it's a surprise attack every time. So same person, same routine, you get the soap out the same, you use the shower the same, you do exactly the same thing. Routine is huge. So that's where I would start as far as bathing and resistance to that type of care.
And just one other idea I would add is very much about approach. And so thinking in terms of this memory being short term, right? There, someone is not able to hold information for long. So even if as a caregiver or a family member, you think that the day before or even 10 minutes before you had introduced yourself and said very simply what you're here to do, offer that again. Good morning, Mary, it's Laura. I'm here to give you your bath. And then you wait again, no words, simple, just offering that greeting. Remembering or doing your best to approach from a place where that person can see you. So more of an eye contact face to face, rather than, offering a command coming from behind as you're walking in, because that may, in the person's mind that is changing, feel startling or feel, unsafe. So just that simple. And even as, Mom, good morning, it's Laura, it's bath day. And then, a pause to wait. So just, just remembering approach and that reintroduction, even if you have been with that person before and they know you, and certainly if you haven't been, and now maybe I'm shifting more to someone who's in a, a home care situation, or they're a more formal paid caregiver, remembering to just offer that as you are, beginning a new relationship. Thank you.
So I would like to add one thing that Melissa had sort of taught me, and that was about aroma. And bath time is often about really nice smelling things. And so I think that's another addition that can help be calming to a situation when people are resistant to care.
And then something that Laura has taught me is that if we know we want to give someone a shower, we don't ask, would you like to have a shower?
Right.
We instead offer other choices. So they still feel that they have some control, and they do have some control, but the choice isn't, would you like to have a shower? The choice is, would you like to use this shampoo or this shampoo today? Or would you like to use this loofah or this washcloth? And maybe we do have some prettier things or some nice things that people can visually say, oh,
You do have one.
grab it.
That's the other thing, is using things that are familiar to them.
This is a handmade cotton washcloth from Melissa's nanny.
But they're wonderful. I mean, because that's what, they're used to, and they're soft. And actually, their studies show that using pure cotton for baths is less damaging to skin in the elderly. So, that's a lot more personal than getting those wipes out that we all have in the plastic bags. So, you know, maybe they have some of these in their home, or you can engage in that way.
Yeah. And then just to say too, if it doesn't seem like it's going to go well, just leaving and just trying again in a few minutes or a few hours, depending on, you know, how long that person's kind of memory is lasting, their short-term memory is lasting at, you know, at the time.
Avoid the battle.
Yeah. Don't, right. Yeah.
Win the war.
So next we'll talk about how to handle people that are trying to elope and wander outside of their apartment or their house.
So, and this, we have some good examples and some good things that really are easy to put in place. If you're in the home setting, a really good, cheap, easy way is the doorknobs that are child-proof doorknobs. They can't turn them. They're not, oh, you know, they don't look ugly. They fit in with the normal environment, but they're not, you know, they're not getting, it's hard for me to get them open. So that's a good, easy way. You get 3 of them for like $5. So that's a good, easy way to do that. Some other things that we've learned is, you know, if it's trying to get in the car, then instead of having that battle, you can't drive, you're not getting in the car, then you just remove the keys, or you remove whatever you need to from the car so it doesn't go anywhere. We don't know what's wrong with the car. We need to take it to the shop. You know, avoid path of least resistance. And then I really, really love the things that you can get on Amazon that look like something else. Like we had a lady who loved, I think it was Paris, and we made it look like Paris in her room. So, you know, the door was covered up by a scene of Paris, and it looks very real. They have the library where there's books, and there's peel wallpaper, peel stick things. So you just stick them on there, and then there's, you know, you avoid that. And then a very simple thing is, and this I can't say enough of, and even as a mom, I use this tactic all the time, just did it very recently, is the soft goodbye. So when you're leaving your person, you know, they don't remember. And if you're going to make a big deal and say, bye, mom, I'll see you later, or bye, we'll see you next time, they're coming with you. So I can't say enough about that slow exits, that slow goodbye. They're engaged in something else. You do the small pat, or even just you say bye in your heart, but then you exit slowly, because that alone has changed a whole lot. We had a man in a facility that we couldn't figure out, like every day he tried to leave, and all the residents were going with him. And one of our social workers came up with she figured out the pattern. It was every day when the caregiver would leave, he would line up all the residents and they would all try to go out the door with them. But what we figured out was it was when the caregiver was leaving, she would say bye to them. So they were going too. So a simple thing that changed that entire behavior was she just stopped saying bye, and they stopped trying to go with her. So that's an easy something to do to stop the elopement.
Noticing also, thank you, noticing also the time of day or when that might be happening might give a clue. Oftentimes, or more usually, we're hearing that it's happening kind of coexisting with that sundowning time, or that kind of later in the day, you know, just turning from, you know, midday to afternoon or early evening. So one of the things to consider is to really have a good routine, excuse me, that you're incorporating during that hour or that time, engaging someone in an activity or something that's meaningful to them, that might offer an ability to divert or distract. That sometimes is not able to work because the tendency or the urge to just walk and wander is just the way someone you know, is communicating. And so maybe at the different points of the exits, there can be something set up that offers some way for the person to kind of stop, momentarily engage, enough for you or someone else to maybe notice and then, you know, take them away. On the larger end of that, of course, and it's again an expanded talk for another time, but there are safety measures that you can utilize, for example, through Alzheimer's Association, their program called Safe Return is an excellent way to register someone and for them to have a pendant or a bracelet that they wear in the event that they do get out and they do wander, that there is some way to track and have that return, person return safely. So that's another, intervention you can take along with some of the behavioral changes.
I might add one where one of my patients' families took all the shoes away. And this man could only leave the house when there were shoes, and the postman would bring the shoes on the days that he had appointments to go out. And it was amazing how well that worked.
I love that. That's good.
Yeah, I think the kind of hard part for me coming from medical and then kind of learning all of this from Peggy and Laura and Melissa is a lot of it is really getting to know the person. And then a lot of it is so much trial and error. And that's even been, I'm convinced of it now. And now I'm the one trying to convince families of it, but that you kind of use every single tool you have. So every single thing the person liked or didn't like, everything, like what they did for work, and just everything you can figure out about them to try to figure out solutions to the different problems that are arising. And that it really is a lot of just trying everything you can think of. And then to add on to your point, Laura, about the Safe Return program, you can buy little GPS things now that you can put like in people's shoes and stuff like that, so that you can actually just see where they are, track them in real time. So that's another safety measure.
And I think Corinne is speaking to the heart of all behaviors is the first time you meet them, get to know, again, find out what you need to know, find out what they did, what their life was like, their family members, everything, because you're going to take all of that knowledge and you're going to utilize it whether you know it or not. I mean, you'll figure out why that they don't want the bath, or you're going to figure out, oh, well, that makes complete sense. We had a guy who was in World War II, and when they put him in the shower, he went berserk and started hitting everybody. That's because he flew in the planes, and the bullets, the water sounded like the bullets. And it took a lot of knowledge. It took the whole team to figure that information out, because it was where he was, what he was thinking about during his day. And but you needed everybody. You needed the family, the team of people to come up with that information. So I can't say enough about taking the time to get to know your patients.
Yeah. And just one final point, actually looping that particular behavior, elopement or wandering, connecting it back to the idea of the communication, right? Behavior as communications. That leads you to think about, what may be happening that's creating that sense of a person wanting to go. And it could be, multifaceted. But one thing is that a person may not be able to really have a clear sense of where they are or what their purpose should be in the space. So they don't know how to initiate what they should be doing at any given time. So that's communicating, maybe a need for something. So to offer a way to feel as though someone is belonging, or they are in a space that's safe and is their home, so to speak. So again, with each thing, reaching beyond the behavior to connect with the idea that some need is attempting to be communicated. The usual channels to do that are blocked because of changes in the brain due to the disease and the progression of that disease. And so, bringing all that together might offer a little bit more of a way to understand or inform you as to what may be going on. And in some cases with the wandering piece of the elopement, some homes and family members have been able to do this. Some communities offer it. don't try to pull someone from that. Just offer a lovely path to walk. Join the person, come alongside them, and take the journey of wandering. They may tire out. You may have a pleasant moment, as a hummingbird flitted by. Stay awake and alert to the moment as well, when you're not able to necessarily change it, or turn it off, so to speak.
Should we kind of talk, we kind of mentioned sundowning.
And I think what Laura was hitting on right there is a lot of sundowning is a communication of restlessness, or maybe there wasn't enough mental or physical stimulation in the day prior to the sundowning occurring. So one of the things is addressing that by utilizing exercise or some type of getting out in the sun. If the person's in the wheelchair, then you take them for the ride in the wheelchair. You get them outdoors in the sunlight. They can't get in the sunlight, which is almost impossible to not get in sunlight here, but they have satellites that we use that you can put at their breakfast table so that they're getting the sun, so that circadian rhythm kind of stays on track. It gives them that piece. But also, I'll give you an example. I had a lady who was sundowning, and every day at 3 o'clock it would happen. And turns out we found out her favorite movie was Sound of Music. So every day at 1 o'clock, we watched The Sound of Music. Every day, every single day, 1 o'clock, because that was her mental stimulation. All the rest of the day, she didn't do very much. She ate. She was a very active lady, but she loved going to the movies. So we had movie day every day at 1 o'clock. We watched the whole movie, and even when she couldn't remember, she remembered. So it was a lovely way to break that cycle without having to utilize medicine or it was great for her and everyone else. So sometimes it's just a matter of figuring out what's missing in the earlier part of the day that needs to be put in there to avoid the sundowning behavior in the evening.
And in going along with what Melissa's saying, it could be a case of someone being understimulated or not having known how to, initiate or engage activities, or they just are not getting a lot of exercise. It could also be there's a day or the pattern of your weeks or someone being overstimulated so that there was too much happening. And by about 4 o'clock in the afternoon, they're exhausted or they're irritable or other things are coming out that are very appropriate to having had a day where you did a lot and you're tired. So in those instances, and this is sort of another foundation or back to a lot of the ways we understand behaviors communication, taking a moment to do a scan of the environment. And it doesn't have to be elaborate. It could be a chair that's in, a favorite corner or a place you set up that becomes a place where someone can sit and be out of maybe more of the noise or the stimulation or the distraction. So again, it's so individual and personal in knowing your own home, your own environment, what's happening there, what may be happening at 10 in the morning versus 4 o'clock. Do new people come in? Is there more coming and going? All these stimulus for a person who's having changes in their brain can cause reactions that can be distressing. So just doing sort of a survey and saying, is somebody overstimulated or are they understimulated? Just in very simple terms to kind of figure out where you might go in terms of the intervention.
And I want to say, I know you guys are thinking we don't have all this time because we're nurses and we have other patients. So what I want to tell you is utilize the family. They want to help. And as you know, and as I do, and a lot of times when you have patients that have dementia, there's not a lot that families can do. And so giving them this is something they can do to help, and they want to. So you explain to them, like, I don't know your mom as well as you do, but sometimes she could be trying to communicate. And you just leave the information and see what they come up with on their own, because this gives them something to do and be part of the care. So sometimes it's empowering for families.
Yeah, I like that idea. Mhm. And just to say, and thank you, Melissa, for kind of bringing that out, because just this format, we didn't have a chance to see exactly, particularly who's in our audience or from what frame you're coming from. But certainly if it's in a more formal professional relationship, it sort of works counter, because there may be things that have to get done or need to get done. There's time parameters around things on you as a person trying to care or to do something when you're not able to, take into account all these things we're saying. So in that way, just almost take what we say and shrink it. You do the best you can in those moments you have, but maybe it's just, realizing that on the front end, if you work out or figure out a few of these things, counterintuitively, it may save some time or may increase the connection or the engagement that's possible, because you won't be sort of clashing against, with someone, you'll be sort of joining with them. So it's a little bit of that preparation ahead before you enter into a space. I know my background has me working in hospice, and for my part, that 2 minutes as I pulled up to a home and I know I was going in, sort of taking that quick moment. You can have your own mantra, your own word, or whatever your practice is, to sort of just release and say, I'm coming in fresh now. I'm going to be present with this person where they are. Even just that simple reminder kind of puts you in tune with what the challenges may be.
I would kind of go back to what Melissa was talking about with music, because sometimes sundowning is a time when a person is really anxious and they don't really know why. It's often difficult for caregivers to deal with, because it's really hard to redirect. And depending on the person and what their life has been, there might be a place for music to engage a different part of their brain that gives them some comfort. And so I want to always make sure that we think of music, because it really does engage a different portion of the brain. And maybe that in itself is kind of a distraction at that time. And it's like everything that we've been saying, there's no one size fits all. We never know what's going to work. We just need to remember as many tricks as we can to give it a try, because when we find that key, it can make a significant difference. So I would just put that out there.
And Peggy, on that note, I just yesterday, this happened. I had a gentleman who was very, very physical, very physically active. And unfortunately, he's not able to do that much physical activity anymore. And we were trying desperately, what can we do in the afternoons that would provide him stimulation, but not overtax him? And we went down the list: no puzzles, no books, no TV. And finally his wife was able to say, he really likes music. And that was the key. It was, let's listen to the music in the afternoons, because it provides that same stimulation he needed, but he's not necessarily having to be outside hiking up the mountains. So it was a really great way to provide calming in that afternoon time.
Oh, absolutely. And if you'll indulge me to say, the team knows this one, but same for me yesterday, Melissa. And thank you, Peggy, for reminding of the music. I was visiting with a couple. There's a lot of progression now and some decline in the disease. And so what's been coming up is the person themselves who has Alzheimer's is dozing off, sleeping so much more, just not able to initiate and engage. And her spouse, the spouse is, I could see yesterday, feeling just lost, and like a connection is starting to really go away. And so he was feeling very down yesterday. So we knew from this person's past that she had sang in a choir, and we're sitting together on the couch, and she had been really eyes closed the whole time that I was there. And then I said, I was thinking in my mind about something with music. So I just kind of touched her gently and said, you know, my grandfather used to sing in the choir at Christmas time, and you sang in a choir. I wonder if your choir sang this song. And rather than asking her, I just started, scarily enough, but I just started to sing Silent Night. Well, opened her eyes, she was looking directly at me, joined in to sing this song from start to finish with the most beautiful voice. And then the husband also came in like with his tenor, you know, he was almost doing like some contrast with our singing, and just, it was just a beautiful moment. And, you know, the hope there is there was some modeling also for this spouse as the holidays are approaching and family is coming, to maybe just start a song. Don't wait, you know, thinking that the person will do it. Get the holiday music out, remember a favorite tune, and start singing.
And I have to just share this one more, because it was actually a patient with you guys with Harmony Hospice, and you probably, some of you will remember, but it was in July. It was not the holidays, but and he was actually very behavioral towards the end of his journey here on earth, and it was really disruptive for the family. There was a lot of them, and they loved him. He was the rock of their family, so it was really hard to watch. But he loved Christmas, and they had their own very strange 12 days of Christmas family version.
Oh, yeah.
And so right at the time as he would become behavioral, the whole bunch of them would just get up and start singing the 12 days of Christmas for their family. And you could just see the peace in his face, like everything would just relax. And it was really good. If you could have a perfect death, I would think that would be one of them, up in my top 5. So music is powerful for sure.
Yes.
Love it. We still have some time here, so we thought we would talk about what to do about repetitive questioning, because we get a lot of feedback from spouses and caregivers that it just drives them insane. So we thought we'd offer some advice on how to help caregivers handle that.
And does anyone have any questions? I've just been monitoring the chat box to see if anyone's got questions. So I'll keep
people or anything you want to bring up. We can interact.
Okay. So any questions, just type them in the chat box and I'll go ahead and read them out.
With repetition issue for sure, going back to kind of the 3 foundational blocks that we talked about in the beginning, and it's sort of a reframing or rethinking about what you are necessarily needing to do in those moments. So very often for many of us, if someone is asking us a request or asking us to do something, or they're asking for follow-up on something and over and over and over, our urge is to try and solve it, to try and fix it and meet that request. And in the instance of this form of communication for someone with a neurocognitive disorder, that trying to reason or rationalize or meet the need with something practical is not necessarily going to be the best path, because the short-term memory loss will require that that's going to come up again, even if you answer it or try to fix it or solve it. So one of the approaches, as we've been talking about, is to listen, reach for what's underneath what they might be asking about. So a validation of someone maybe missing someone, or a validation of feeling upset or nervous about something. And so you could even say, yes, it sounds like you're really worried about, whatever it might be that's coming up. And then again, not going forward with more words, just allowing for your offer of some validation to show that you heard that person. And then they, in some instances, and we've been seeing this recently with someone we're working with, they may then be able to pick up on that as the signal to just keep talking and expressing and emoting. And then you're there to hear what it is that they're talking about. In these instances, it often becomes useful to offer some distraction or diversion. So you might respond directly to what that person is asking about, so that you're not, sort of condescending or making the person seem like they're childlike. You're hearing them and you're directing. But then shortly after that, rather than staying on that topic, which is an obvious point of distress when it comes to rumination, come up with something to divert. So if you're meeting someone and approaching, look for something they may be wearing or a color. Say, June, you look lovely in this shade of pink. And all of a sudden, you're pulled off of that. And it may come back around again, because we know in very many instances, there's profound short-term memory loss, but you can use that to maybe move it along,
And I'll say, example with Laura, just the one we are dealing with this now, she wants to go home. And she's with it enough to know she could go home, but not enough that she doesn't remember how we've explained how she can't go home. So exactly that. And it becomes this battle. By the time I got out there, 40 caregivers had already told her she's not going home. So she was mad, they were mad, and she was ready to let me have it. So we sat down and I listened to how, that she needed to go home. And the only thing that I got in the whole piece was she mentioned something about New York. And I said, I hear you want to go home. Did you know that our social worker, Laura, is from New York? And boy, that was it. Off we went on this New York story. And so for 30 minutes, we talked about Laura's New York and her New York. But that was it. And so it was a good way of showing the caregivers, instead of talking to her about this over and over, just find one piece where you validate, you showed you were listening, but you're not talking about it anymore. Like you're moving over to something different. Mm-hmm. And I know I saw one of a question about the angry one. What is that? The question.
Do you want to,
yeah. Erin asked, she said, my question is on angry, repetitive questions.
And is it, can Erin tell?
Yeah, the story, yeah.
If
let me see.
And I just will mention too, one, we had a really challenging client whose pet died. And I know it's a lot of, where's, or a relative, for people, a relative has died and, hey, where's, so-and-so, where's my dog? And we don't really, if a person cries and gets horribly distraught every time you have to retell them like, oh, so-and-so died. Every family is different, but we might just not tell them over and over like the sad news and make them relive it. Just instead, you're really missing, so-and-so. And then, and then trying to change them off. Okay, looks like Erin can talk.
Hi, thank you. So I'm with Adult Care Assistance. Hello. And we have a client who has probably like later early stage dementia. She is obviously a little aware that something is going wrong, but she has, anosognosia. She doesn't understand that she has memory loss. And she's very angry. And so we have a caregiver who goes and sees her twice a week. And every time the caregiver shows up, it's an argument of, why are you here? Why do I need you? What are you doing here? And the entire shift, she's explaining to her why she's there, and just any recommendations would be so helpful.
Oh, Erin, So much to say there. So in the incident, the person that Corinne was actually just talking about with the pet that she had lost, she was very similar. Every time the caregiver would get there, it was, it was really bad. But again, it's that constant engagement of the same story. So I came in at 8:30 with my bag of stuff that had nothing to do with her living there or being there, or the caregiver being there. And I had my kid's tortoise and some stuffed animals, some stuffed dogs, some cards, like just distract. I knew she crocheted. I just laid it all out on the floor in front of her. Like I came in and I was like, oh, I'm gonna go get us some coffee. And I left her alone with all of the stuff that I knew she had some connection with. And then I went to get our coffee and I came back and here she has my little tortoise in her hand, like it Petunia, and she was petting Petunia. And then I said, oh, here's your coffee. And we talked about Petunia and how, it was going to get really big. And that was it. We had days and days and days of not wanting the caregiver there. But as soon as that caregiver didn't look like she was a caregiver anymore, and I know that's hard in the time of COVID, but we took her scrubs and we tied a jacket around it where it made it look like a sweatshirt. She came in, she was like, hi, I'm your daughter's friend. And she's like, oh, I see you've got Petunia. She started petting Petunia, and that was it. That was the whole thing. I mean, did we have to repeat this whole scenario the next day? Yes, we did. But it got better, and to the point where she started to recognize the caregivers as her friends or her people. Get out of the cycle. You're not going to win. So I can't say enough about you gotta go in with something totally different and just completely change the dynamic.
Yeah, that's awesome. I love the idea. We have another client who we actually go in without scrubs because we don't want to trigger her behaviors, but it just, she doesn't actually have dementia. She just has behaviors. So it didn't really occur to me to try that with this one. So that would be a really great idea.
Find out something about something she likes. Find out a relative, find out a grandson. With the lady that wants to go home, she loves her 11-year-old grandson. And so we stick to that. Like, find a topic of something that she doesn't know necessarily that your caregiver knows, and have the caregiver lead in with that. So-and-so wanted me to come visit you today. Oh, she told me you really liked red roses. I brought some. Can you help me? Whatever. Like, find something that changes as soon as she walks in, that she's not there to take care of her.
Yeah, awesome. Thank you so much.
Yeah. And Erin, this is Laura, in that particular instance too, it's as much as almost, offering that caregiver the permission that he or she does not have to respond to the direct question, why are you here? What are you doing? That's the place where, pulling off of that sort of practical, rational response, you can leave that aside and know you don't have to necessarily, go into all of that. But as Melissa's offering, that you bring other things or bring something else up, but it takes practice almost because it's an instinct and it's the natural thing. If someone says a question, you think that's the road you need to go down. So it's kind of reminding and giving permission. You don't have to go down that road. You just try a different road, meaning,
go for that redirection
and then see where you go.
Yeah, and we had another lady, I think Laura ended up figuring this out, when one of the caregivers, her phone was broken, and the caregiver fixed her phone, and that was good enough that day. Oh, she came and she fixed something for me.
Yes.
Or we had the caregivers try
that was the purpose. Yeah.
Bringing her takeout food that she liked. Hey,
I love in the chat box, the kits. That's a great idea. We all, I think I can't say enough about having something in your bag of tricks. My kids are great distractions. A lot of people, as soon as you pull out the phone and you're like, oh, you had a daughter, I have a daughter, let me show you my daughter. And so that's always in my bag of my agitation kit. So let your caregivers have fun with it and give them that permission to engage in whatever story is needed. And that's a lot more fun than fighting with them for 2 hours. So give them that permission to enjoy the story. I don't want to miss this next question either about
Yep.
Talking about doing things with dad every day, even though he has been deceased for 20 years. Is there ever a time to correct them?
No, don't correct. You just listen, and you again, there's a great point where whatever they're telling that they're doing, latch on to something in that sentence, and then you can say, let's get the whatever out, or that's their grieving in way, that's their communication of grieving, and maybe they need to do those activities to get that need met. What kind of things are they talking about doing? Is there something you could do in there? The question there. I don't know who that is.
Yeah, it came in under anonymous, so
Okay. I know.
Oh,
I just
and that's okay.
reposted it.
I would just don't correct them, and I would try to, listen to it as a way of they're grieving, and maybe pick out something that you could and do with them to help them get those needs met.
And just two quick things on that. That's both that place where whether it's, something that's rational or true, or it's irrational, that ends up not really mattering as much, because the perception of what that person is needing and bringing that up is happening regardless. So as you said, just picking up on maybe something, keeping in mind too, though, as you on the receiving end of that, you're in a different place from what's coming at you. So acknowledging too that for you that might be triggering as you're having your own path through, grief, or remembering or not remembering, or feeling you've moved on. So, allowing or figuring out how you put in your own emotional boundaries, how much, you can stay there and listen, or how much you can switch and try to divert so that you can move away and perhaps get your own break from your own constant reminder of that, and wanting to say it's not true, but just remembering that person is not able to really think about it in the same way that you may be able to.
Yeah, I really like that point about just even being aware of your own emotions and your own feelings, and we all have them, and
Sure,
that's okay, and that gives, give yourself a break and give yourself a chance to acknowledge what you're feeling, and
Without judging it. Yeah. Good questions.
Yeah.
Anybody else have any stories or questions?
Don't see any yet.
Well, it's almost time. So we'll just say thank you all so much for coming. And we actually, I've met Erin, which is really nice. Networking can pay off sometimes. So yeah, we're elderhealthathome.com. If anyone wants to talk to us further or get together for lunch.
Questions.
Yeah, just email us there. Get in touch with us.
Thank you so much. Thank you for taking time out of your day to do this for us. We appreciate it. Appreciate all the information.
Nice.
Thank you, everyone.
Bye.
Thank you. Bye-bye.
Bye-bye.